what we were doing last week was just a little intro to IR. All right, can you guys see my screen?
Yes, we
Yes.
can.
Yes, we.
So we'll skip this. We talked a little bit about, the different imaging modalities we use. We talked about different, tools that we use in IR. And since we didn't have Choi, like last time, we'll just quickly run through this briefly just to recapitulate. So we talked about biopsy guns, and I told you guys that it's nice to have a biopsy gun where you have like a blunt introducer needle, how that sometimes can be helpful, right? We talked about different drainage catheters. We talked about the sizing of different devices. We use gauge typically for needles, and the smaller the gauge, the bigger the needle, right? Which is counterintuitive, but that's how it is. And then we talked about French sizing, right? So 3 millimeters, 3 French being 1 millimeter. So, a typical drain that we use is 10 French. So it's just a little bit over 3 millimeters. We talked about different types of access needles here, micropuncture set, right? 21 gauge needle, 018 wire, and then a transitional 3 5 French dilator. Talked about Chiba needle, trocar needle, and then like AccuStick or Jeff set or Neff set. There's different names for this, but that's what I mean when I say like it's a triaxial access kit. We talked about different wires. Here's a J-tip wire, but then you have stiff wires such as like Amplatz wire or Landerquist. You have hydrophilic wires like glide wires, etc. We talked about Seldinger technique, which basically just means you access a space such as a vessel or any other space really in the body. You get a wire in, you then exchange your needle for a catheter or a sheath, and then through that you can do whatever you need to do. And the guiding principle is essentially that you do not give up access, right? So it's always about exchanges, but never about just removing everything. So you're exchanging one thing for another. Talked about different sheaths and dilators and different catheter shapes and sizes depending on what you're doing and what you're trying to achieve. You may need different catheters. And again, it's not like every IR uses all of these, right? So a lot of these are, you can use one or the other, and often what ends up happening, whatever you're most used to is, what ends up being your go-to catheter for certain things. But you do need to be aware of other options because sometimes the anatomy just doesn't allow you to use what you usually use. So then you want to be aware of alternative catheters that you can use instead. We talked about different embolic materials here, starting with like the most basic gel foam, which is just sort of a gelatin sponge, which you then just cut into little pieces and you mix it up and you produce a slurry. You can also make little torpedoes like they do here and use that. Some people do that, for instance, after liver biopsy. They just load up the guiding cannula with a little torpedo and you just push it in with a little saline. So that's even quicker than producing the slurry. We talk about different coils. Here you see some fibered coils, right? So there's different coils, detachable, pushable. Here you see what it looks like when you're deploying a coil. I talked about plugs, particles, right? These down here are embospheres. We commonly use them for prostate artery embolization or uterine fibroid embolization. Balloons and stents, again, many different sizes and shapes available. Here's your balloon. This here is a balloon-mounted stent, and this here is a self-expanding stent. So the self-expanding stent comes with this inner expansive force, and it's loaded up in a sheath. And then once you unsheath it, it just opens up on its own. Versus the balloon-mounted stent, who doesn't have the built-in expansive force. So this one you have to open up the balloon in order to have the stent stick to the wall. All right. And then we looked at a few cases. So we talked here about cholecystostomy placement in the setting of acute cholecystitis, right? So we had a distended gallbladder with a thickened wall. We talked here about essentially using salving a technique to do that. So you do a transhepatic access. We talked about pros and cons of going transhepatic. With a needle under ultrasound guidance, you get your 018 wire in, you use your triaxial dilator, get your 035 wire in, and then you push in your drain. And typically you would do, I usually like to put in a 10 French drain for these. Some people do 8 French. I usually think 8 French is a little too flimsy, but you know, if it's a patient with coagulopathy, you're really concerned, maybe then you opt for an 8 French. And then we talked about this, you know, somewhat tricky biopsy when you have a lesion that's more central in the abdomen, different techniques, how you can get there without going through bowel loops. So we talked about displacement. So sometimes you can just push the ultrasound probe down firmly. And with that displaced bowel, as you can see here, sometimes you can also, what you can do is you can actually strap something on the patient to push things apart. So Doug Sillin, one of my colleagues here at Yale, he came up with it. It's just like a bowl, just like a bowl that you would use to eat soup. You just cut a hole in the middle and you can strap that onto the patient's abdomen and then displace with a belt. And with that, displace the organs and then do a CT-guided biopsy through that hole in the bowl. And what I did in this case was using the blunt needle. So I just got into the peritoneal cavity, switched from the sharp needle tip to the blunt needle tip, and then just maneuvered my way in between the bowel loops using CT and ultrasound guidance until I got to the lesion, and then did the biopsy. We then talked about this guy here who had hypotension after paracentesis, right? Had with the big rectus sheath hematoma, with the active extravasation here. We discussed how when you have bleeding coming from the inferior epigastric artery, it's advantageous to get contralateral access, right? Because as you can tell here, I mean, you see the inferior epigastric comes off here. If you're getting ipsilateral access, it's very difficult to get in here because you essentially have like no room to work with, right? So instead, what we do is we get contralateral access. We go up and over through the aorta, down the contralateral side. In this case here, I'm using a 6 French long sheath, a Balkan sheath. And then with, you know, a 5 French catheter or 4 French catheter, you can then access the inferior epigastric artery. We saw the bleeding here. And I think it was Alex who discussed this case. Then we correctly said you have to try to get across and then you coil back, right? Because you could also have inflow coming from the superior epigastric. So you don't want to just coil in the inflow here. You ideally really want to try to coil across the site of extravasation, right? So you do here, and then you do a follow-up run. You now see there's no more bleeding from this side. And then I think the last case that we did, I don't remember, was it Sam or who was discussing this? We had a 7-year-old with a large mass obstructing his SVC, and in the setting of a lung cancer. So here, typically, if you have like a central lung cancer, you would expect either squamous cell or small cell lung cancer. I think this was a squamous cell cancer. Anyways, in this case, again, you just get IJ access, you get a stiff wire across all the way down into the IVC. You then do angioplasty, you know, using large balloons. So here you probably use, I don't know, 12, 14, or 60 millimeter balloon. And then if, you know, given that there's a malignancy, this is probably not going to take care of it. So then we deploy the stent across the site of obstruction here. And I think this is where we ended. Is that correct? Do people remember?
Yes, that's supposed
Okay,
to be.
perfect. Then, one of us, why don't you then just start with this next one here then? Now we have a 38-year-old female with heavy menstrual periods and cramping lower abdominal pain. What do you think when you hear that?
So from the history, I think this patient presents with has signs and symptoms of uterine fibroids.
Exactly. And then what do you usually do for the workup of these?
Basically, first and foremost, we need to take a proper history from the patients. We need to correctly identify what will be our indications for uterine artery embolization, because apart from uterine fibroid, we have some other indications such as PPH. And after that, we'll need to do our workups as usual. As first and foremost, we know this patient would have undergone an ultrasound, so we'll need to do an MRI to confirm the location of the fibroids. And the MRI will be contrasted because we'll need to see if there are multiple fibroids, we need to see if they are taking up contrast. And so apart from location, we need the MRI will tell us the number of the fibroids. And also, we will need to do our other labs, like we need to know the baseline HB of this patient. We need to know the number of platelets. We need to do a pap smear because we need to rule out malignancies. In some other countries, they do endometrial biopsy, but to us, it's not routinely done. And also, we need to do a UPT, as well as have a coagulation profile aside and creatinine, because we will use contrast, so we need to know the baseline of the renal functioning of this patient. And
Right.
other
and the other reason to get the MRI is also to rule out malignancy, right?
Yes.
Because like with ultrasound, you can often see there's fibroids, but you know, anytime if you have a woman with bleeding, especially you should be suspicious if someone is older, of course. And MRI can be very helpful to rule out that there's malignancy on top of what you already said. Great. So this was her MRI. So, you know, essentially what you would expect, right? So you see here large uterine fibroids. And then tell me a little bit about the actual procedure now and sort of advantages and disadvantages of radial versus femoral access for you.
Okay, so the advantages, I would start with the radial access. The advantages of radial access is early mobility. Just after the procedure, the patient would be able to ambulate. However, the disadvantages of radial access is because the arteries are small in caliber as compared to the femoral, then it's very prone to spasms. And then one would be very careful when accessing the radial artery. And the advantages are the femoral access, we highly use it because a larger caliber. And however, the disadvantages is if we encounter like an emboli and it's dislodged, then there's a risk of ischemia. That's why after the procedure, when we go to look up to our patients, we need to do to look up on the femoral as well as on the dorsalis pedis artery.
Yeah. And, you know, so additional disadvantage of the radial access, because, you know, you're working close to the carotid arteries, there's always a theoretical risk of causing stroke, right? So for instance, if you were by accident to introduce air or there's a clot forming, that would go directly to the brain, right? And this is why we typically do a left radial access, so that we're not, the subclavian artery comes off last from the aortic arch, right? So then when you're coming through the left subclavian, you can go directly down the descending aorta, and you don't have to cross the common carotid arteries. Okay. Good. So then we talked, you know, you already mentioned that the radial artery can be quite small. So there's like some workup that we typically do before we do radial access, right? So there's two things. Have you heard of this test here that's depicted on the left?
Yes, the Babot test, which is also known as the modified Allen's test.
Mm-hmm. And what's the point of that, or how do you do that?
Okay, so basically we in a patient in a supine with the arm outstretched, we try to compress both the radio and the ulnar arteries, which we need to know if we've compromised the radio artery, we'll need to see the ulnar artery will be taking over, because these two arteries have to have a communication, the deep and superficial palmar arches. So upon we'll have a pulse oximeter, which will be showing us the waveforms. So what we usually do, compress both the radio and the ulnar artery, and then we release the ulnar artery, and we will be observing 4 kinds of waveforms. We have A, B, C, and D, in which in the A, the waveform type A, this is regarded as a normal waveform, and it is interpreted as we have excellent collaterals. That means after there is return of normal waveforms upon release after 2 minutes. However, other literatures say about 1 to 2 minutes. So in the second one, which is the B, initially you would have a blunty waveform, but it would return to normal or after 2 minutes. And in C, you have there's like complete loss initially, but however, after 2 minutes, the waveforms would be returned. However, this is usually regarded as not well collateralizing. And in the last one is the D waveform, in which there's no return of the waveform after 2 minutes. So
Okay.
Some people would take A, B, and C. However, some other literatures say a good candidate would be the one which have waveforms of A and B.
Yeah, I agree. I mean, for me personally, like if it's A and B, I'll proceed. Usually if it's like C or D, I won't. But it also depends a little bit on the indication, right? Because, when you're doing like a uterine fiber embolization, you might as well do femoral. So there's really no need to kind of push the boundary versus, maybe if there's a different procedure where you absolutely really need radial access. So then you may be willing to also do it with a type C. Then on top of that, what I like to do before radial access, that I take a look with ultrasound and actually measure the artery, right? So
Okay.
for as we discussed last time, when you have a vascular sheath, right? Typically the inner diameter, if you have a 6 French sheath, the inner diameter is 6, the outer diameter is 8 French, right? Now, for radial access, we typically use the slender or slim sheets. So they are only 1 French bigger on the outside than inside. So if you use a 6 French slender sheath, it's only 7 French on the outside, right? So that's why 7 French is how much in millimeters? It's like around 2.3 millimeters, right?
Yeah.
So that's why we measure, and typically I want to see that the art is at least like 2.1, 2.2, or at least I want it to be over 2 millimeters, so that I can use a 6 French slim sheath. So we see the artery here. Again, you can also put color on, make sure you see flow, and you take a look at the ulnar artery. So you get access here. Once you get access to the radial artery, what do you need to do, which is not needed for femoral access?
Okay. There's a combination of medication that's needed. That it's like a cocktail. I remember it's we have nitroglycerin, we have rapamycin, and I can't really recall the third medications.
Heparin,
Yes.
usually.
Oh.
So I usually do, there's like different, cocktails, but what I do usually is like 200 of nitro,
Okay.
2.5 of verapamil, and 3,000 of heparin. And it's kind of easy to remember that way. It's like 200, 2.5, 3,000, right? So it's like 2.5, 3.
Yeah.
The verapamil, the calcium channel blocker, is very painful when you inject it. All right. So usually when we do that, I have my sheath in, I draw up the cocktail in a 10 cc syringe, but the volume of the cocktail is only around like 4.5 cc. But so I hook it up, I fill it up with blood to dilute it, and then I very slowly inject it.
Okay.
All right. And then you really want to make sure that then your sheath is connected to a sidearm drip, right? You want to have a continuous drip going through there.
Okay.
All right, great. So now you have your axis. Now you go down into the iliac arteries with a let's say 5 French catheter. This is like a 5 French Bernstein. How do you angle your tube in order to access the internal iliac artery? What's the easiest way to do that?
Okay, so we
sorry to interrupt. I just wanted to ask about the cocktail that you give. I can understand why you give nitroglycerin and heparin, but why do you give verapamil?
The verapamil, it's just to decrease spasm. It's to open up the artery. Both the nitro and the verapamil help with opening up the arteries and decrease spasm.
Thanks. Sorry, one of us, you can go ahead.
Oh, okay, fine.
No, and you guys ask questions anytime. If anything is unclear, just ask. All right. So one of us, how do you angle your gantry here? Your tube. How do you angle your
Okay,
II?
so from these DSA images, with the catheter coming from contralateral side. Okay, so that means we've accessed on the right side. So first of all,
no, this is like radial. The catheter here is just coming from above. But what I'm asking is like, what's the easiest way to get into the internal iliac artery? Do you just look AP, or is it helpful to angle the tube ipsilateral, contralateral?
So in order to be able to delineate the branches, the internal and external iliac, we need to do contralateral, oblique, preferably
Exactly.
30 degrees.
Yeah, exactly. Like you can do like 20 or 30 degrees contralateral, that really opens up the internal and external. Then you find your way into the internal iliac. And once you're in the internal iliac artery, then typically you rotate your tube ipsilateral oblique. All right. Again, you can do like 25, 30, 35, whatever you want. But this then usually helps to open up the branches of the anterior division. All right. So now you see your uterine artery, right? It's quite large in this case, coming off here and going towards the uterus. So this is like early arterial phase. This is a little bit later. So you see how all of these branches here, it's supplying this large fibroid uterus. So now how deep do you want to get into this uterine artery?
You really want to, because the uterine artery has like three causes. You have the descending, the transverse, and the ascending. You really want to get, I think, at least to the ascending part, because you want to identify branches such as cervicovaginal branches, in which if we inadvertently embolize that, then this patient will present with sexual dysfunction disorders.
Exactly. So you really try to get through the horizontal into the horizontal portion. You try to identify the cervicovaginal branches, and then typically, once you get into the vertical portion, you're safe. So we did here. You can see went with like a high flow microcatheter through the 5 French catheter through the horizontal portion up into the vertical portion, bypassing cervicovaginal branches. And then we do the embolization. And what particle size do you like to use for uterine fibroid embolization?
500 to 700. Some are saying 700 to 1,000.
Yeah, I usually start with like 500 to 700. I give 2 vials of that, and then if there's still room, then then I go up to 700 to 900. And then I give another 2 vials of that. And then if there's still flow, then I do gel foam after. All right. But basically the idea is, you know, that this somewhat smaller particles in the beginning travel all the way sort of deeper into the tissue, and as that starts filling up, then you upsize your particles and, you know, you fill the bigger branches. All right. And then what's your endpoint for the embolization?
Usually it's regarded neostasis.
Mhm.
We have up to neostasis.
And how do you measure that, or how do you try to quantify that?
Quite
What people often do is like they say, like, you know, 5 to 8 heartbeats, right? So what you do is like you just do like a contrast puff, and you see the contrast kind of just sitting here, and you count like 5 to 8 heartbeats. So you do like 1, 2, 3. You know, I mean, you see it pulsating, right? So you just count along, and you know, if you have like, if the contrast remains there after like 5 to 8 heartbeats, then you're good. All right. Then you just pull your catheter back, you come down on the other side. Here again, same thing. And right here you see some of those cervicovaginal branches coming off, right? The stuff going down here. So you want to bypass those, and then you do the same thing on this side. And then, you know, some people do, some people don't do an aortogram either at the beginning of or at the end. I typically do it at the end, because, you know, we already know, like, either way we're going to embolize the uterine artery, so we can go ahead with that. But then after that, you do an aortogram. And what are you looking for in the aortogram, one of us?
I mean, before the procedure, or?
Yeah, like why do we do the aortogram? Is there something else that you're looking for here? Basically, you're looking if there's any other supply to the uterus, right? So you can see now we're doing the aortogram here. We no longer see the uterine arteries, right? The uterine arteries are already shut down, but we're looking if there's any ovarian supply, all right? So the ovarian arteries come of the aorta here, and they look really like squiggly, all right? They look like little, you know, they look kind of similar to like uterine artery here, just like usually even smaller, and like these very tight turns. All right, so they're relatively easy to recognize once you've seen one. And now, if you do see an ovarian artery supplying significant portion of uterus, you then have to consider, okay, should I embolize it? And the way I was taught is that if you were to see like 2 ovarian arteries, you could consider embolizing one of them. But you would kind of, you want to be careful with embolizing all 4, all right? Because then there's a higher chance of necrosis. So I think typically what people do is if you do see bilateral ovarian arteries, you consider embolizing one of them.
Thank you.
All right. Great. Then who else do we have here? Oh, maybe Himidi. You want to take this one? Or whoever else is available?
Okay, yes.
I have a question, maybe
Yes,
before this one.
go ahead, Alex.
Okay.
Yeah.
So for patients with a postpartum hemorrhage where we're embolizing the uterine artery to reduce the hemorrhage, we don't worry about the cervical vaginal branches?
Well, a little bit less. So typically, you know, I mean, first of all, like when it's postpartum hemorrhage, it's usually an emergency, right? So they're really kind of bleeding out. They sometimes can already have coagulop, you know, they can have been DIC, and they're just like bleeding. So in those cases, what you want to do is you want to use gel foam, because, you know, it's considered like a temporary embolic agent, and it's really just about getting something in there and stopping the bleeding. So yeah, you're typically less concerned about, you know, looking at little branches. On top of that, often because they're hypotensive, they're bleeding, all of their arteries are totally clamped down. So it can look very, very different from what we looked at here, where you see like a huge uterine artery, very easy to get in. It can look very different. Everything can be very clamped down. The arteries can actually be tiny. So there's some cases where you can't even get into the uterine artery. All right. If you can get into the uterine artery, even if you can just get into the origin, you just give gel from there until you slow down the flow, and that's it. If you can't even get into the uterine artery, you may even have to consider if you just gel from the entire anterior division. All right, so you just put gel from in the anterior division. That's it. All right, so yeah, you are a lot less precise often, first of all, because it's emergent, and second, because the arteries are much smaller, and the goal there is really to just to stop the bleeding as quick as you can.
All right, thanks.
All right, Himidi?
Okay. Yeah, for the 2-year-old male presenting with chest pain and shortness of breath.
Mm-hmm.
So
So
this one,
mm-hmm. Go ahead.
okay, in front of me is a pulmonary angiography, CT angiography, whereby we see the filling defects in bilateral right and left pulmonary arteries. More on the right, which is occupying almost 100% of the lumen, but harsh on the left.
Good. All right. So now, how do you, or actually, first, what other workup is needed here to determine whether this patient could benefit from any treatment? So we already know he's symptomatic, right? He's presenting with shortness of breath. We know he has clot in his bilateral pulmonary arteries. Is there anything else that you would want to do in terms of workup?
Yeah, in terms of workup, first we did CT angio. I would need to establish the classification or the grading of the embolism, whether this is massive, submassive, or mild form. But given the clinical picture, it's not mild form, either massive or submassive. So we need to assess whether the patient has a heart strain or not. And from there, if the patient will benefit from IR interventions, we need to do a blood workup. The baseline, like full blood picture to know the HB, platelets, INR, and also potassium before we decide to select this patient.
Okay. So in terms of the massive, submassive, etc. So usually now more commonly people say like high, intermediate, and low risk. All right. So you stratify it into those three categories. And it's actually not really related to the imaging appearance. All right. It can sometimes be tempting to, if you see a lot of clot, you just call it a massive PE. But the determination is actually just based on labs and the clinical status of the patient. All right. So if you have like a high risk PE is a patient who's hemodynamically unstable. All right. So this is someone who's like, tachycardic and hypotensive. All right. Or it is someone who has already syncopized, right? Someone who passed out. Those are considered high risk PE. All right. No matter how big the clot burden, they can have, actually quite a small amount of clot, but maybe they don't have much cardiac reserve. And that would still be considered a high risk PE, or formerly massive PE. Now, if you have an intermediate risk PE, this is someone who's hemodynamically stable, but they do have either laboratory abnormalities, meaning elevation of BNP or troponin, or they have right heart strain on the CT, or even better on echo. All right, so meaning hemodynamically stable, but signs of right heart strain either by labs or imaging. And then the low risk PE, this is now someone who's hemodynamically stable and who has no signs of right heart strain, right? So troponin, BNP are normal, and echo shows no right heart strain. All right. And even if they have a large amount of clot, they would be considered low risk. And we would typically not recommend a thrombectomy or lysis, but instead they would just be put on heparin and be monitored. All right.
Okay.
So now, if you let's say this guy is kind of at the border of intermediate to high risk. So he has laboratory abnormalities, he has right heart strain, and actually he already syncopized at home before coming into the hospital. So now you do decide that you want to treat him. What are the options?
The options would be catheter-directed thrombectomy, which would give an immediate relief for this patient. The second, thrombolysis, which is medical, but it might take time.
Good. Yeah. And even before that, so for instance, now if let's say you get called about this patient from a hospital a little bit outside of DAR, and they show you these images, the most important thing is you tell them immediately put this patient on a heparin drip. Okay? They need to be started on a heparin drip immediately, and then they can be transferred to Muimbili. And now when they get to Muimbili, as you said, there's the options of doing thrombolysis or doing thrombectomy. So now, if you don't have thrombectomy devices, what you would do for thrombolysis is you could simply park a single pigtail catheter here in the main pulmonary artery, or even better, if you have two, you can park one over here in this clot and one over here, and then you just run CPA or some other thrombolytic through that. Typically, you would leave it on, overnight, or at least for like 6 to 12 hours, and then you can bring them back to a repeat pulmonary angiogram, and then hopefully the clot has been lysed and you can remove the pigtail catheters. Now, in this case, we did a thrombectomy. So here's like a flow retriever catheter. There's different brands and devices that you can use for that. But the way we typically do it is we get right common femoral vein access. We use a pigtail catheter to go up and through the heart. All right. Once we're in the pulmonary artery, we measure the pressures here. Anything over 25, mean of 25 is elevated. We do pulmonary angiogram. I mean, sometimes we just start sucking clot right away, but sometimes we do an angiogram just to kind of map out where the clot is. As you can see here, there's clot sitting over here, and there's clot sitting all the way down here. It's a little hard to appreciate in this image, but basically everything is full of clot here. And then we just do this thrombectomy, and then do a repeat pulmonary angiogram and repeat pressure measurements, and that's that. Here's just a little video. This was actually a clot from the it was in the right atrium and right ventricle, and we're just pulling out the clot here through the groin. So because sometimes, as you can see here, sometimes you can suck the clot through the flow retriever, but if the clot sometimes is too fibrous, it's not going in through the catheter, and your catheter just kind of latches onto the clot. So then you have to pull everything back together and then try to pull it out through the sheath. But sometimes the clot doesn't even fit through the sheath. So then you need to pull out everything over the wire without losing access, and remove the clot. All right, so you can see here in this case, this was a 20 centimeter clot, so it was about this long. All right, then why don't we continue here maybe with Alex?
60-year-old male with abdominal distension and multiple episodes of upper GI bleeding.
Mm-hmm. What are like two common mechanisms for upper GI bleeding?
Esophageal varices and also peptic ulcer disease.
Exactly. Great. So now, if I tell you this guy is an alcoholic and has a long-standing history of liver cirrhosis, which are you more suspicious of?
I'll be more suspicious of esophagoviruses and also maybe gastric viruses.
Yeah. And what's the best way to find out what type of bleeding it is?
We can do as an abdominal CTA.
Mm-hmm. And let's say you do a CTA, you do see some signs of cirrhosis, but you don't really see much else. What's like the surest way to find out, the gold standard? Not something we do. We have to ask our colleagues.
Oh, endoscopy.
Endoscopy, right? So any patient presenting with upper GI bleeding should undergo endoscopy. All right, it's very very important. So now, but of course, sooner or later you do get imaging. Okay, so let's say they did endoscopy, they found a bunch of large varices at the GE junction. They banded some of them, but they say there's persistent oozing. The patient is now somewhat stable, but they reach out to you and say, can you take a look at this? So here you have your triple phase CT. The things you're looking for, you're just trying to outline the anatomy. You see a very shrunken down, tiny xerotic liver, right? And then I don't know how many images. I don't really have additional images, but then let's say you see gastroesophageal varices, and you confirm that the portal vein looks patent. All right. So now, how do you go about doing a TIPS?
So with the TIPS, I would have to first get pre-procedure blood workup,
Yeah.
CBC, PTINR, and also calculate the MEL score for the patient to make sure it's not above 19. I think above 19 is a contraindication because patients have increased mortality.
And it depends on the situation. Yeah, I mean, if they're acutely sort of bleeding and you have to do an emergency TIPS, then obviously you care less. But if it's an elective TIPS, yeah, I think different people have different thresholds. But 18, 19, I think is where people often draw the line. Okay.
So my access for the TIPS procedure, my access would be through the right IJV. Through the Saldinger technique, I'll obtain access into the IJV, go down into the IVC, and send the catheter into the right hepatic vein.
Do you know how you can confirm if you're in the right hepatic vein?
Yes, with a positioning of my X-ray source, you can get a lateral image to make sure that the catheter is not going distally. However, it's coming towards the X-ray source. Because
yeah, exactly. So the right hepatic vein is often, it's confusing, but unfortunately we can't see it in this image, but the right hepatic vein is essentially usually at one level with the IVC. I mean, sometimes it can go a little posterior, but typically it's kind of just at the same level. All right. So when you look at your next CT scans, look at the right hepatic vein, and you see that it sort of just goes sideways. However, the middle and left hepatic veins, they go more anteriorly, right? So when you do the lateral view, you basically just want to make sure that you don't see your catheter going anteriorly. Yeah. Okay.
So at that point, we measure the wedge pressure we measure the pressure within the right hepatic vein, and then use there's a sharp stylet that we can use. You push it forward to try and target the right portal vein, and then you can pull it back to see if you have blood flow. You can also use I think intravascular ultrasound scan if you have that available to help target, or even percutaneous ultrasound scan in some cases.
And what is this image here on the right?
So this is it's a venography. They're using carbon dioxide to try and outline the portal vein.
Yeah, exactly. So you can do a CO2 portogram, and that's helpful to do basically before you do your sticks, so that you have a target. All right, and that way you know, because otherwise, you don't really know how far to puncture, especially like in a small cirrhotic liver. You don't want to puncture further than you have to. So doing a CO2 portogram can be very helpful. And as you said, even better, of course, is if you have like intravascular ultrasound guidance, because then you can have live guidance. But in order to do that, you need to get into sheaths, and of course, you also need the intravascular ultrasound, which are quite expensive sometimes. So many people prefer to do it sort of the old school way, just with a CO2 portogram, and then using that as a target. All right, great. So you described, and when you do your puncture, you turn your guiding cannula anteriorly, right? So you're here in your right hepatic vein. You turn it anterior, meaning you turn it counterclockwise, right? You have it in here. You turn it counterclockwise, which is anterior, and then you do your puncture. And there's different types of puncture sets that you can use. Rosh Hashida, Ring. There's now something called like Scorpion. I think there's yet another one. But the idea is always the same. You have typically a hollow needle. Some of them have a little plastic catheter on the outside. So in the case, you puncture in, and you have a small syringe on the back filled with a little bit of contrast. You just fill this syringe with like a quarter or a third of contrast, and as you're pulling back, you're aspirating. All right. Once you go through the portal vein, you should get blood back, and then what you do to confirm is you inject contrast. As soon as you have confirmed that you're in the portal vein, you get a wire down. Typically, people use a glide wire. And then over the glide wire, you can get a catheter down, you get a stiffer wire down, and typically an Amplatz wire. And then over your Amplatz wire, you can get your sheath down. But what size sheath do you typically use for these?
I think it's a 9 French.
Yeah, or 10. Typically, you need a 10 French to deploy the Viator. So people, for the most part, use a 10 French sheath. All right, so by the way, often when you have like a really cirrhotic small liver, they can be very tough tissue. So even getting your sheath down can be quite difficult. So sometimes you need to like pre-dilate the track, right? So I usually use like a 6mm balloon. I open this up, and then I get my sheath down. All right. So now you have your sheath down in the main portal vein. You do your pressure measurements. Pressure gradient is elevated. Let's say it's 20. And now what do you do next?
Then you place a stent between your fistula, in the fistula between the hepatic vein and the portal vein. You place it's covered and non-covered. Half of it is covered and half of it is non-covered. So you place the covered side within the portal vein, prevent thrombus from forming there.
No, so the uncovered portion is in the portal vein. So typically it's like 2 centimeter uncovered, and then the covered portion is the portion that's in the tract. Okay. The reason being that if you have uncovered stent as you're passing through the hepatic tissue, bile would be sort of seeping into the stent, and bile is thrombogenic, right? So then you often get stent occlusion. So typically the stent that we use is called a Viator, 2 centimeters uncovered, and then can be anywhere from, I don't know what the shortest one is, maybe 4 centimeters or so, but it goes all the way up to, I don't know, 8, 9 centimeters. I'm not sure how long they make them, but you essentially want the covered portion to cover all of this, and the uncovered portion to be here within the portal vein. And meaning that before you do that, you have to measure the length of your track, right? So we typically use like a measuring catheter like here. So you have these 1 centimeter markers on there. you bring that catheter into the portal vein, you then pull your sheath back into the hepatic vein, and then you inject them at the same time. So you inject through the sheath and through your catheter at the same time, as you see here. And then, oh no, actually this is not a good image. So after that, pull back. But then you can map out, okay, here you see where the hepatic vein ends, and here you see where the portal vein comes, and then you can measure how long you need your stent to be, all right? And you want to cover from where it enters the hepatic parenchyma here from the portal vein all the way up to the hepatic vein IVC junction, right? If you make it too short on either side, it's gonna go down, all right? So we did our measurements, we deploy the stent, and then you do repeat pressure measurements. These stents, they open up automatically to the Viators to 8 millimeters, all right, on their own, and you can then dilate them further up to 10 millimeters. All right, so then you just use a balloon, and then you just arrive at an adequate pressure gradient. Typically you want to be somewhere between 8 to 12 millimeter mercury in gradient, depending on if they had acute bleeding or if they had ascites. Great. Good job, everyone. All right, I think we'll wrap up here because I have to see a patient in 2 minutes in my clinic. So yeah, good seeing everyone.